I'm going to talk to you a little bit about why and how we use transfusions in MDS, how we measure their benefits, and a little bit about iron chelation. So why do we need transfusions for the treatment of MDS? And I'm not going to kind of go into too much detail about sort of the mechanism of myelodysplastic syndromes, as I'm sure many of you know already. But one of the key mechanisms of anemia in MDS is this accumulation of mutations that lead to reduced production of all types of blood cells. But one of the most common ones that's affected is the red blood cells. And so anemia is almost a universal symptom in people with MDS. And the symptoms of signs of anemia, things like fatigue and shortness of breath, are actually quite common before people know they're diagnosed and they're not really sure what's going on. But there's other symptoms, including palpitations, headache, anxiety, difficulty sleeping, pain and weakness, just to name a few. And they contribute to quite well documented findings that anemia really impacts people's quality of life in myelodysplastic syndrome. And actually, we know that it's very important, not just in people's quality of life, but also the prognosis of people with myelodysplastic syndrome. And we use various different scores to work out sort of if people are low risk or high risk. And anemia is quite an important item in that score to determine sort of how severe and how likely things are likely to progress. So transfusions are a commonly used treatment in MDS, and as we saw from the show of hands at the beginning, a lot of you have, if not having regular transfusions, have had occasional transfusions, and actually between 50% and 90% of people will need a red blood cell transfusion at some point during their journey with MDS, and many will then go on to become dependent on red cell transfusions. That's somewhere between 30 and 50% needing, sorry, well, yeah, it is somewhere between 30 and 50% that will go on to be dependent, but actually also 30 to 50% will need to have platelet transfusions as well. Many of you may be on EPO, erythropoietin injections, or you may have been on them in the past. And this is a hormone that's naturally occurring that basically sends a signal to your bone marrow to make more red blood cells. And it's normally made in your kidneys, and it regulates how many red cells you have. But we can create this artificially and give it to people to send a signal to make more red blood cells. And so people who are anemic, it's something that we can try to improve that. And often that's the first point of call where we go. We have another hormone called GCSF that improves the amount of white blood cells that you make. But actually, coincidentally, we find if we give both together, sometimes it helps the amount of red cells that are made as well. And so we try this on many people when they're first diagnosed with MDS. But unfortunately, whilst often it does give a sort of short-term effect, it doesn't seem to work particularly well long-term. And probably only about 20% of people get much benefit from that. And so then despite these EPO injections, they go on to continue to be anemic. And so that is when we start to think that transfusions are something that we need to do. And actually, we've seen that sort of hemoglobin levels in men and women, so less than 90 in men and 80 in women, is independently associated with worse survival and non-leukemic and cardiac causes of death. So being anemic is not a good thing, as we've said in the prognostic scores. And so we have to work out ways that we can improve that. This is an image from a study which some of you actually may have been involved in a few years ago. We did some work with the Oxford Blood Group here in Oxford, asking people with MDS sort of what their priorities were in their treatment and how MDS affects them. And we sort of created this image from some of that information. But it just kind of shows that anemia is really complex. And we've been looking at the relationship between anemia and quality of life for many, many years. I think there were huge studies in the 80s, not with MDS, but in cancer. trying to understand this relationship and what level of hemoglobin makes people have certain symptoms. And it's really complicated. And I don't think there is a simple, this level will cause this. And it's also really individual. And so I think what we're learning is that there is no set anemic level that affects people in different ways. What I also want to kind of add on here is that it's not just the kind of things that we said. So shortness of breath, tiredness, low energy, feeling weak. But if you look in the sort of clouds around the side, it's also all the other things that contribute to that, which perhaps we're not very good at measuring. So the impact on people's emotional well-being, the impact on their daily activities, the impact on their social life, their sleep, and also the financial burden of all of this, not just to hospitals and giving blood transfusions, but to people with MDS and their families having to come to appointments, come and wait to have their transfusions, and the impact that can have on their life, their jobs, and that sort of thing. So it's a really complex thing that we need to look at. And I don't think it's very easy to measure with a single thing, which makes it quite difficult to do research in this area. This is a really nice article that was written by Erica and Zoe, who are two haematologists down in Melbourne in Australia. And it talks about the role of transfusions in low-risk myelodysplastic syndrome. And this is a nice image that sort of highlights how we approach transfusion support in MDS. And so on the left here, I'll just turn my pointer on. Hope you can see that. You can see on the left the pre-transfusion considerations, so sort of the symptoms which we spoke about, but also how well the patient is, so their performance status, which is something we use as clinicians, where we use a 0 to 4, where 0 is completely healthy and 4 is really, really struggling, not really able to get out of bed very well, and everything in between. Their comorbidities, so their other health conditions. But also it's a discussion with patients with MDS, and so what they want and what they value. We also spoke about how we use laboratory results, primarily hemoglobin, but also alternatives to transfusion, things like EPO and GCSF injections, and whether we've tried those. And then there's the actual giving of the blood. So we have to select the right product. So we have to make sure that blood is matched, that it's not likely to cause any transfusion reactions, that we can give it in as safe a way as possible. But obviously, as many of you who've had transfusions know, it takes a bit of time for the blood to go in, and it's not just the time that the blood is going in. There's all the time in between where you go and get your blood test before, where you're waiting around to have the cannula put in, and you're waiting to be let into the day unit or wherever you're having the blood. So there's lots of bits there. And then hopefully not many of you, but some of you may have had an adverse reaction to blood transfusions, and these can range, and we'll talk about them a little bit later, from very mild, sort of feeling a bit funny, having a bit of a temperature, to more serious shortness of breath and other issues. So there's a lot of monitoring that has to happen when people are having the blood. And then with anything, we have to actually understand if what we've done is a good thing. So we have to evaluate if it's helped. And that's where it can be quite difficult because, as we mentioned before, it's very complex and it may help in some ways, but it may not in others. And so how we measure that can be quite difficult. So we can evaluate the symptoms. We can use quality of life questionnaires, and there's various different ones, which some are good, some are bad, some look at different things. We can look at functional outcomes. So how, if people are getting back to work, if people are being more mobile, that sort of thing. And it's also important we minimize long-term complications, and we'll talk about iron overload and chelation a little bit later in the talk. So this is another table from that same study, which just sort of talks about red cell transfusions. And I've also added in the platelets here. I'm not going to talk too much about platelet transfusions, but I think some of you may have had platelet transfusions as well. And we use them in similar ways. It's very much a supportive measure to improve symptoms that people may be having. So particularly with the red cell transfusions, the aim is to improve both the short-term and long-term symptoms of anemia. So the short term is things like fatigue, shortness of breath, but long term, actually, if you're anemic for a long time, the heart starts to have to work harder, and it can get bigger, and then people can get a degree of heart. And so it's important to long term minimize that happening by improving the anemia. We also want to improve functional outcomes, and we measure this using a blood test, hemoglobin, which is the level of red cells, and functional measures, things like a fatigue score from those quality of life questionnaires that I was talking about. But we also do a walk test, so how far people can walk in a certain time distance, and also grip strength. So people sort of grip a device and it measures how strong you are. And they have been independently reported to correlate quite well with how people are. And obviously the reason we're doing that is to control the symptoms, to give people a better quality of life and allow them to get on with their day-to-day activities, which they would be doing if they weren't anemic. And that's primarily the aim of what we're trying to do. So I want to talk about this measure of the benefits, so these hemoglobin thresholds, and where do they come from? Because I think this is a real downfall in how we're measuring the effect of transfusions. So clinically, we use generic hemoglobin levels and also our clinical judgment as clinicians to determine how often and how many units of blood we give. And this data has come from trials that were all done in an acute setting. And what I mean by that is people who were in hospital. And the outcomes of those trials were severe effects of anemia, things like having a heart attack and having ischemia in certain organs. So is this relevant? Well, for someone who's at home and trying to get on with their day-to-day life, I'd argue that it's not. So it's sort of very good from a safety point of view, but from quality of life and allowing people to get on with their lives point of view, I'm not sure we're extrapolating this data correctly. There's very few trials in transfusions that have been done in patients with hematological malignancies, and there's no studies that have been done in chronic transfused patients with other blood diseases, things like aplastic anemia and myelofibrosis. And so there's a real lack of evidence in the setting of outpatient transfusions. So whilst we have lots and lots of data of what we should be doing when people are in hospital, we have very little data on what we should be doing when people are out of hospital. And most people with myelodysplastic syndrome are having transfusions. And so how are we measuring that? And some of you may have had experience of coming in and being told that you don't need a transfusion based on a hemoglobin, whereas you feel and sort of knowing yourself that you do, or it may be the opposite where you feel okay and you're coming in and you're told you need a transfusion. And so there is, there's some work to be done on how we can do this best and improve the use of transfusions. And the other thing, sort of, I think not so much in the last 5 to 10 years, but prior to this, the objective of many of these studies was try to reduce the amount of blood that we use, because blood is expensive, it's a finite resource. But is this really the correct way that we should be doing it? We should be measuring it on the benefit that we're giving, the benefit that we're giving people who are having the blood transfusions. But as we've mentioned, measuring that is quite difficult. I just want to highlight sort of, this is a study that I did with that same group in Australia that we published last year. And we did a systematic review. And what that means is we look at all the studies that have been published to see if we can actually learn something that we may not have seen in one study, but by looking at all of them, you've kind of you can see some trends in the data. And what we were doing is we looked at every study since 2000 where people with myelodysplastic syndrome had some sort of treatment to improve their anemia, whether that be EPO, whether that be some sort of drug, or whether it be transfusions. And we looked at the impact this had on their quality of life and also their physical function. Alongside that, we also looked at the effect it had on hemoglobin. And what we found, scientific studies, a lot of them published in very well-regarded journals, is that we weren't really measuring quality of life very well at all. And so it was quite difficult to find a sort of trend in what happened. And the reason that is because we're not measuring it very well. And so it's really hard to change guidelines and change what we do in clinical practice if we don't have the data. But if we're not collecting the data, then we're not going to be able to do it. And so I think that's a real downfall that we've found. So we've talked about why blood transfusions help the symptoms of anemia, and why it's important to do that to improve both short-term and long-term side effects of being anemic. So you might ask the question, why don't we just give everyone very liberal transfusion policies? So if you're feeling a bit tired, we just give you some blood and improve that. And I think there's quite a lot of reasons why we don't do that. And I want to talk about a few. As I mentioned before, blood is a scarce resource. In the UK, we use voluntary donations only. And so it is a very sort of, we have a stock of blood, but it is being replenished constantly and we're using it constantly. And it's a very sort of labile system whereby there's a lot of work that goes in to make sure that there's blood available. But we only keep blood for 35 days. And so it has to constantly be replenished. And some of you may have read in the papers, I think it was the end of 2022, is the first time they issued an alert. We called it an amber alert, meaning that we were short of red blood cells. And what that meant is a lot of work happened behind the scenes to reduce the amount of blood that we were using in hospitals. And actually, in some cases, surgeries had to be cancelled. So it is very important that we're not using blood unnecessarily, because it's not something that we have an unlimited resource of. As I mentioned before, blood transfusions are also, they're not risk-free. There's a lot of work that goes in to make sure that the blood transfusions are safe. We have to match them to people. We have to check people don't develop antibodies. We also have to, be very vigilant that people don't get allergic reactions or overload where you have too much fluid going into the body, and it can put some trouble on the heart, kidneys, and lungs. And this second picture at the bottom is a picture from the SHOT report. So SHOT stands for Serious Hazards of Transfusion. And they're an organization that really, they're there to promote good transfusion practice. And so they develop guidelines to ensure transfusions are safe. But they also monitor the things that can go wrong each year and produce a report across the UK, which is a huge amount of work, but it's very useful to see trends in what are happening. And if you see on the bottom, these are the years from 2010 to 2022. And I wouldn't worry too much about the top bit 13, but this is all the deaths that we say are transfusion related, and the top bit in red is delays. And I wouldn't say that's too relevant in this case, because that means people didn't get a blood transfusion when they were bleeding and needed it acutely in hospital. But the other ones are all where things have gone wrong, which with a bit more forethought, we possibly, I'm not going to say definitely, but possibly could have prevented. And one of the big ones is TACO, which is transfusion-associated circulatory overload, which is this orange one here. And so 8 people in 2022 died from TACO. And that's because we're giving blood too quickly and it's putting too much fluid into the body, and the fluid goes into the wrong place and causes problems with the lungs, kidney, and heart. And so what I want to say, it's not just a give as much blood as we can and things will get better. There is a balance to be had, but we do need to understand that balance better, I think.